Welcome, Professor Kalla, to this presentation. Thank you.
Good afternoon, Chair, and thank you for inviting me to speak at this Congress. I hope you can hear me. I'm presenting from South Africa. Is my voice coming through and my slides, are they up on the screen? Thank you very much. So basically, the talk that I'm going to be delivering over the next 30 minutes is going to focus around another form of extracorporeal support therapy, which is basically in the form of respiratory and cardiovascular support. I must congratulate the previous speaker. He did a fantastic job on speaking about renal replacement therapy. And now we're going to go on to the next form of pulmonary or plasma support, which is basically extracorporeal support. And basically what we're looking at in terms of this form of therapy is we're looking at supporting the cardiorespiratory system as opposed to the renal system or the renovascular system. In order for us to understand, ECMO or rather ECLS support therapy, I think a few of the, nomenclature needs to be addressed up front. And what's important for us to understand is that there are various different methodologies by which we can deliver, we as intensivists can deliver ECLS, which is extracorporeal life support therapy. The forms of therapy that are available to us are what we would start off by calling ECMO, which is extracorporeal membrane oxygenation. The other one is ILA, which is interventional lung assist. We use a device that's a non-pump based device. The other one is ECHO 2R, extracorporeal carbon dioxide removal. And this is very important for you as nephrologists because the ECHO circuit as well as the ECHO filter is something that's now been devised in such a way that it's attached to the CRRT machines. So ECHO 2R could be delivered through a single circuit with a form of heme adsorption, which is a mass form of therapy, as well as CO2 removal through the PlasmaFlex CRRT machine. And then the final form of ECLS support therapy is where we actually implant a ventricular assist device to palliate heart recovery, either in the form of severe end organ heart dysfunction or for patients who've got as a bridge to transplant. So what's the main principles with regards to ECMO therapy? The most important principle is basically carbon dioxide removal and O2, and the insertion of the O2 or the application of O2 into the plasma. So basically what you're doing is you're trying to mimic the function of the lungs. And the two most important aspects about mimicking the lung function is one is what would be referred to as ventilation, which is CO2 removal, and the other one would be oxygenation, which is a form of therapy by applying, some form of a PEEP or membrane diffusion to get oxygen into the systemic circulation. The aspect about ECMO that needs to be remembered is that it can be delivered through one of two ways. The one way it could be delivered using the same circuitry and using the same circulation principles and the same pump via a veno-venous ECMO device where blood is removed from a venous catheter and then reinserted via a venous catheter into the right side of the circulatory circuit. So either into the right ventricle or at the level of the tricuspid valve or into another major vein. The other form of therapy that ECMO allows us to perform is what we would call a VA ECMO. And here, what we're trying to do is not only are we trying to support the respiratory symptom, but we're also trying to support cardiovascular system as well. And here, what we're trying to do is we're trying to enable enough circulatory support, not just respiratory support, to enable blood flow to the more vital organs like the brain, and the major organs in the abdomen. What are the main physiological functions with regards to ECMO? The most important one, as I mentioned, is O2 delivery and removal of CO2. What we need to remember is that with regards to O2 delivery, it's not necessarily only met by increasing plasma or partial pressure of oxygen in the blood, but also by improving blood flow. And VA ECMO improves blood flow as well as oxygenated blood within the circulatory capacity of the body and to the vital organs, whereas CO2 removal is purely a function of diffusion. So if we look at the ECMO circuitry, and my previous speaker has spent a lot of time looking at circuitry. I'm not going to focus a lot of time on the circuitry because the principles are much the same. But what we see in terms of oxygenation is that the amount of oxygen as opposed to when we are ventilating patients. So ventilate patients' oxygenation principles are completely different. When we're oxygenating patients through a ventilator, the main function of oxygenation is mean airway pressure and FiO2. With regards to a form of extracorporeal support therapy, the main function of oxygenation is basically the amount of blood flow that enters the membrane or what we would call the external lung. The amount of oxygenation that's passing through across what you would look at as the diffusion aspect of the circuitry. So this is where you would run your dialysate. Here we run in gas. This is the same part where we run in blood. And here where you're looking at your kidney function, we talk about a membrane, which allows for diffusion of oxygen into the blood and carbon dioxide out. So the amount of oxygen that enters is determined by blood flow, hemoglobin, as well as the FiO2 of gas, of oxygen that's within this part of the chamber here. In terms of carbon dioxide removal, the two main aspects that determine the amount of CO2 removal within the ECMO circuit is one, not necessarily blood flow. You can have very minimal blood flows. That's why we talk about echo with, even 100, 150 mils of blood per minute. But the membrane, so the efficacy of the membrane, the amount of the porosity of the membrane and the function of the membrane with time, and then the flow rate of gas within this chamber. So the flow rate of the dialysate gas or the dialysate fluid, as you would be more familiar with in terms of speaking as a nephrologist. So what affects the ability of this oxygenator or this lung to function properly? And the most important thing is condensation within the oxygenator or within the lung, within the chamber, and thrombin and fibrin formation along the membrane that actually affects the dialysis or rather the diffusion of gases around this way. So what you must remember, as opposed to a CRRT circuit, a CRRT circuit, to the best of my knowledge, the kidneys that you use or the dialysis chamber that you use functions for the maximum of maybe 72 hours to 96 hours. Whereas in an ECMO circuit, we cannot afford to change this oxygenator on a very regular basis for several reasons. One, cost, it's a significant cost to the patient. Two, the risk associated with removing the oxygenator. And three, the complexity of stopping the circuit, because this is a high blood flow circuit, as opposed to CRRT, where we were talking about blood flow rates of 100 to 200 mils a minute. Here we're looking at 2,000 to 3,000 mils a minute of flow rate. So, the entire circuit needs to be shut down. And during that time, the patients can become significantly hemodynamically unstable, and we might even lose those patients. So we have to protect the oxygenator as to the best of our ability. But in prolonging the life of the oxygenator, this membrane then becomes or loses efficacy because of fibrin and thrombus deposition within the layers of the membrane. So how are we, approaching? How do we approach a patient who needs to go into ECLS or basic extracorporeal life support therapy? What we need to understand is that either the therapy is going to be driven by a functional pump, and this means that this pump actually sucks blood out, as opposed to a centrifugal pump, which you are used to on your CRRT or on your dialysis circuits, where you're using a venous circuit and all the pump is doing is moving blood through the machine. Here, blood is actually being sucked out from the patient and then returned at a high pressure. So the conceptualization of this particular form of therapy is completely different in terms of the flow principles and the flow rates that we achieve in transitioning from ECLS to versus CRRT. The second one is that the motors or the pumps that we use are completely different. We don't use rotator pumps. We use Levertronic pumps or centrifugal pumps, where we can generate a significant amount of flow rates without traumatizing the red blood cells. The third issue is cannula line access, and I'm sure you're all familiar with cannula line access. But what we need to remember here is that because we're going to be running such high flow rates, 3 to 6 liters sometimes per minute, then you need to understand that the vascular access needs to be significantly larger. Where we're looking at a 12 French for a Quinton line. Here we're looking at somewhere anywhere between a 24 to a 32 French catheter for ECMO circuits. And then what we need to remember is that how we set up the circuit. Will we use a single port, dual port, 2 venous access, 1 arterial access? All these contribute significantly to the efficacy of ECLS therapy. So when we're looking at vascular access, where do we generally look at vascular access? It's usually by far and away the most common are peripheral forms, where we either cannulate the neck, we need a large vessel, or we cannulate the femoral arteries or femoral veins. But we can cannulate centrally. We can cannulate the aorta, we can cannulate the inferior vena cava, or even one of the other major vessels. But that will require a surgical intervention, or sometimes it's done in theater while the patients are having cardiothoracic procedures. Again, as I mentioned, you can either use a single or a dual port catheter. With regards to the cannula types, as opposed to, or as similar to the ones that we use in CRRT, where we use a single catheter for both, removal and returning blood flow, we have a similar catheter that we use for ECMO, which is called Avalon. I'll show you that. As opposed to the majority of the bypass circuits that we use during cardiothoracic surgery, where we use dual ports. So we use a separate port completely for sucking blood out. So we use a separate vascular access port for venous drainage, and a different port for arterial return. So what has really made our life a lot more easier in terms of delivering ECMO therapy has been the advent of a single port, two-stage single cannula Avalon catheter, which is now also been made by Novolung. The usual site of this particular catheter access, as opposed to most of the other catheters, is not the femoral artery, but the subclavian vein. The important thing is that what we need to focus on is that the return port, blood is usually sucked out from here, deoxygenated blood is sucked out from here through what we would call the distal port or the venous port, and sucked out through the entire ECMO circuit, through the lung, oxygenated, and then return. But the important part is that the return flow has to be directed through the tricuspid valve, so that it flows directly into the right atrium and directly into the pulmonary circulation into the left ventricle. And that's important because if we don't deliver the blood at this particular point here, then what happens is that we have a recirculating phenomenon. So what are the modes or the configurations? As you heard our previous speaker talking about CRRT as broken down into CVVH, CVVHD, and CVVHDF, and maybe even a bit of SLED or IRT. What we have in the ECMO circuits, and what we have in the ECMO nomenclature and ECMO delivery therapy is we have veno-arterial ECMO, we have veno-venous ECMO, and both these two are pump-based ECMO therapy circuits. And then we have what we would call a non-pump-based ECMO therapy circuit, which relies on an intrinsic cardiac capacity of the patient to pump blood through just an oxygenator or a lung, and then returns through the venous circulation. And in this particular mode of therapy, all what we're trying to do is we're trying to do a bit of echo-to-R, or removal of carbon dioxide. So as opposed to renal replacement therapy, where the primary disease pathology drives the indication for therapy, in ECMO we need to define the purpose, because first of all, it's highly costly. Secondly, it's fraught with complications. It requires a significant staff complement, a significant amount of expertise, and it's very demanding on the ICU capacity when delivering ECMO. So when we define the purpose, what are the questions that we need to ask ourselves? Is there a need for just respiratory support, or are we going to be supporting both cardiovascular and pulmonological support? The second question that's vitally important to us to determine before we introduce ECMO therapy is the process that we're going to be supporting reversible? And is it reversible within a reasonable amount of time? It's no use keeping ECMO patients, on this ECMO circuit lifelong. I mean, I personally have looked after ECMO patients for up to 68 days, and eventually the patients have succumbed, to their underlying disease process. And that was at the time when we were beginning, to find our way with ECMO in the early 2017, 2018 time. So one needs to define the purpose for the replacement therapy. And definitely another form of ECMO support is for organ replacement, but you cannot introduce ECMO support in an environment where you don't have access to organ replacement. So if you have end-stage lung disease and the ECMO is only offering support but not recovery, or not allowing recovery, same for the heart, then one has to be very pedantic about where one considers introduction of this particular therapy. So again, the indications for ECMO are completely different. In ECMO, the purpose for the therapy is far more important than the diagnosis. So what is the purpose that we would use as an indication for ECMO therapy? One, is it a bridge to organ recovery? Do we anticipate that the lungs or the heart is going to recover? If that's the case, then it's a viable indication. Is it a bridge to organ transplant? Do we have an organ transplant facility where we're going to either replace the lungs or the heart? And if we don't, then that's not an indication. And is it a bridge to either a more definitive form of therapy? That means you're going to introduce an LVAD and then transfer the patient to a a transplant center, or are you just buying some time to offer the patients some form of palliation? And that to me is the least most important indication or purpose for therapy in a cost-constrained environment like Africa, where we all practice in. Again, when we look at the indications, as I mentioned, considerations are far more important than contraindications. So again, is reversible lung or heart disease is transplant not an option? Is there massive active hemorrhage? So if you have got an uncontrolled or uncorrectable coagulopathy, or you have intracerebral hemorrhage, as opposed to CRRT, ECMO is not indicated in these patients because you have to significantly anticoagulate these patients, use heparin infusions for prolonged periods of time, they become profoundly thrombocytopenic, and you will just make the situation much worse. And then, is the underlying pathology irreversible? Do you have end-stage renal failure? Do you have significant primary, marrow failure post, transplant or post other forms of bone marrow transplant or other forms of chemotherapy, where the underlying pathogenesis of the disease functions as a contraindication and impacts on our consideration for introduction of therapy? So what are the main indications for therapy? And we would divide them into two: reversible respiratory failure, when this would include ARDS, severe pneumonias, acute asthma, inhalational, pneumotoxicity like hypersensitivity, pneumonitis, near drowning, where we don't anticipate the patients have had significant anoxic brain injury, post-traumatic lung contusions from severe polytrauma, bronchiolitis obliterans in childhood or in children, or even maybe as a function of some form of graft-versus-host illness, and then autoimmune lung diseases like vasculitis, Goodpasture's syndrome, where we know we have therapy, and if we introduce the therapy early enough, we might be able to achieve some form of reversal of the underlying pathology that's pre-existed. What are the contraindications? There are absolutely, or rather there are no absolute contraindications to ECLS therapy in respiratory failure. But relative contraindications is upfront in a patient where you are already 7 days into respiratory support therapy from a ventilator and requiring significant amount of support. FiO2s are more than 90, plateau pressures are more than 30, where the lungs have already become completely stiff. Then introduction of ECMO in these patients at this late stage might not actually, afford any form of recovery. Major pharmacological immunosuppression with absolute neutrophil counts, because these patients are highly prone to sepsis. Again, as I mentioned, CNS hemorrhage, with or without, an expanding hematoma. Non-recoverable comorbidities, such as, again, CNS major damage, if you've had, anoxic brain damage in a near drowning incident or severe polytrauma with significant DAI, then those patients would not be upfront, considered for ECMO therapy. And obviously a terminal malignancy, which is stage 4, and the patient's, predicted mortality in the next 6 months is anything above 60%. For cardiac failure, any form of cardiogenic shock, acute myocardial infarction, myocarditis, decompensated cardiac failure, post-cardiac, post-cardiac cardiotomy shock, or even the Takasugu syndrome, and a peripartum cardiomyopathy would all form as excellent indications for ECMO therapy or ECMO support therapy in patients who require in VA ECMO, and obviously septic shock. What are the major or minimum standard operating principles that one needs to adhere to in the delivery of ECMO therapy? So we need to make sure that we have a significant amount of blood. These patients bleed not just because of the insertion of such large bore catheters, but because of the machine and its ability to hemolyze blood. We need to make sure that we do daily electrolytes, make sure that we're not losing magnesium. We need to check that the liver is functioning appropriately and we're not getting some form of ischemic hepatitis or high flow, hepatitis, or even embolic, hepatic infarction. We need to do daily, or even sometimes BD, full blood counts to look for platelet counts and look for hemoglobin. And then on day 5 onwards, or any patient who's starting to spike therapy, spike temperatures, we need to do blood cultures, because the circuitry is not easily changeable. The lung has to be protected. Sorry, let me rephrase that. Not the lung, the external lung or the external oxygenator needs to be protected at all times, as well as the flow catheters and the cannulas, because we just can't change them. They are extremely costly and they're very difficult to change. And then we need to make sure that we're not allowing the circuitry to clot up in any time or fibrin to deposit on the membrane, because that will decrease efficacy. So we need to make sure that we check a ACT and an APTTD on a regular basis. So it's extremely cost intensive as well in terms of just affording this therapy to critically ill patients. So what are the indications, absolute indications for respiratory therapy? According to the also guidelines, which is the the ECMO Society, we can afford it to any patient where the respiratory failure is got an estimated mortality rate of 50% or more, and that's a relative or should be considered and should definitely be indicated when the risk is 80% or more. So how do we predict a 50% mortality rate? We use a Murray score of 2 or more and an FiO2 of 150, or an 80% mortality risk is predicted by using an FiO2 of less than 80, on an FiO2 of more than 90% with a Murray score of 3 to 4. This is a picture of a Murray score, and it's an important tool that we use to determine which patients will qualify for ECMO therapy after we've gone through the indications and contraindications. How do we go about weaning? What are parameters for weaning ECMO therapy? One is, if we're using it for respiratory, we want to make sure that the primary respiratory pathology is reversed, the chest X-ray is improving, and the lung compliance is improving on the ventilator. So the lungs are becoming less stiffer and are becoming easily to ventilate. Furthermore, we want to make sure that when we do a blood gas, that we've at least achieved, a PaO2 of more than 60, so we're achieving enough oxygenation reserve, that the patients can ventilate appropriately, that the PCO2 is less than 50, and we've reversed the metabolic as well as the respiratory acidosis. And then if we've achieved all of this, then we can try what's called an oxygen challenge test. And what's an oxygen challenge test? An oxygen challenge test is to see that on stable ECMO support, if we increase the FiO2 being delivered to the lungs by whatever means, whether it's through high flow, whether it's through ventilation or through just a non-rebreathing mask, if we can increase the amount of PaO2 prior to the challenge and post-challenge, then we know that the lungs have got a reserve or a recovered capacity for maintaining oxygenation. And that would be a very important a test for us to see if the patients are being able to wean from the ECMO. Right? In terms of cardiac parameters, we want to make sure that the heart rate improves, systolic blood pressures as well as diastolic blood pressures have improved. You want to make sure that we've diuresed the patients appropriately. The central venous pressure has come down nicely. Patients do not have any significant amount of acute renal failure. That urine output is maintained, and we want to see that have we achieved our goals of ECMO support for the heart. So here's our blood lactate come down, and here's our central venous oxygen saturations improved. And again, we want to physically look at the heart in terms of echo, and we want to see that the cardiac silhouette on the chest X-ray is improving. Right? How do we wean? We can wean by decreasing the plumb flow rate, by decreasing the oxygen or the fractional oxygen delivered. We can decrease or improve the ventilatory settings, increase the P per bit by improving lung recruitment. And then more important is we want to decrease the FiO2. And by this, I'm talking about the FiO2 not on the ventilatory circuit, but on the ECMO circuit. So when we look into the blender, we want to try and decrease the amount of oxygen that's being delivered in the dialysis chamber or in the gas chamber of the extracorporeal lung or the lung circuit. And then we want to reduce the sweep speed flow rates to try and reduce the amount of oxygen that's been removed by the ECMO circuit. Just to mention a few of the complications, because this is a highly anticoagulation dependent therapy that we offer. Patients are always at risk for bleeding. They can get intracerebral hemorrhages or strokes. They can get surgical site hemorrhages. Because the catheters are so large, we have to remember that those catheters can induce limb ischemia. They can block off the renal veins and the renal arteries. You can get renal failure. And then because the flow rates are so high, you can induce ECMO-induced lung injury or flow-induced lung injury, or even a reperfusion form of injury at the initiation of ECMO therapy. And then most of these patients are significantly sedated, so you have to worry about skin ulceration, systemic infection, and all the rest of the complications that come with treating a patient in ICU. When we want to think about it in a more, algorithmic approach, or in a more, logistical way, we can talk about patient-related factors, circuit-related factors, and then obviously emergency factors as a result of the complications of ECMO therapy. What are our targets for therapy when we determining, appropriate ECMO support? We want to make sure that for VA ECMO, we've got a hemoglobin saturation of more than 90%. For VV ECMO, where we know the lungs are injured and we're not going to get 100%, we want at least a 75%. We want to make sure that we've got adequate perfusion. We want to make sure that once initial respiratory and hemodynamic goals have been achieved, blood flow is maintained, and it can be maintained at that rate. We want to have continuous oxygen oximetry. We want to make sure that we're monitoring the pressures at the different circuitry within the ECMO circuitry. So at P1, which is pre-pump, P2 pump to the lungs, and P3 from the lungs back to the patient. So we want to monitor pressures within those three circuits to make sure each of those circuits are functioning appropriately. We want to make sure that we're maintaining adequate blood flow rates through the cannulas and through the lungs. And then most importantly, it's no use giving oxygen to a patient who's got no neurological function. So we want to monitor neuro status at all times. And then obviously anticoagulate our patients. What are the specific complications with regards to VV ECMO? Recirculation is a very important concept that we need to remember. And what this basically means is that what we're doing is we suck in the same blood that we've oxygenated and reoxygenating it. So we're not allowing for oxygenated blood to bypass the right side of the ventricular the right side of the ventricle to the left side. And this is particularly a problem with VV ECMO, where we have continuous recirculation and not enough oxygenated blood entering the systemic circulation. What how do we mitigate against that? We can increase the distance between the two cannulas. We can use a single port cannula and make sure that the return port is sitting directly over the tricuspid valve, or we can introduce another drainage cannula, in the opposite groin or in the opposite side of the body, just to try and facilitate and increase the distance between the removal and the return ports. In terms of VA ECMO, what specific complications? Pulmonary hemorrhage, cardiac thrombosis, because here you must remember you've got retrograde blood flow in the reverse, going up from the aorta back to the lungs to maintain coronary perfusion pressure and to maintain blood flow into the brains through the coronary through the carotid circulation. So what happens is that you have a stagnant amount of blood in the heart, because the heart is now unable to pump against the blood flow that's coming back. So you've increased the afterload on the heart significantly. So this stasis can cause thrombosis, and one has to be cautious about that. That's why all these patients need to be fully anticoagulated. And then you can get coronary cerebral hypoxia because you're not getting enough perfusion to the major two organs that you're trying to support with VA ECMO. One peculiar syndrome related to VA ECMO is what we call the Harlequin syndrome, where saturation of the upper part of the body is lower than that of the lower part. So you must remember that the blood flows in a retrograde fashion up the return cannula back to the heart. And for whatever reason, if the blood flow in that area is not significantly high enough and mixes with blood coming out from the heart, then you get a significant hypoxic upper half syndrome, and you get what we call this Harlequin syndrome, where you have some significant anoxia to the brain and to the heart, and these patients might suffer a significant anoxic brain injury, and you get what we call this blue heads or red legs syndrome. Do we have any evidence to support the use of ECMO? And I'm only going to discuss, in the interest of time, 3 important trials. One was the CESAR trial that was initiated in 2006 and then published. The findings were published in early 2010, late 2011. And basically what it looked at is the efficacy of ECMO, in a controlled environment. And what we found was that, ECMO was definitely superior in terms of mortality outcomes to conventional ventilatory support. And it did offer some benefit, right? And this was then, compounded, or the therapy was then, the indications were then increased when we had the severe H1N1 epidemic, where a significant proportion of patients who had just, single organ dysfunction with influenza H1N1 were also offered ECMO therapy. And this is a publication from the NZ group. When we took into consideration all of this, a recent publication, very recent publication, 2019, the Eolia publication, with a similar group of investigators as the previous, investigators that published the CESAR trial in the Lancet, looked at basically extracorporeal ECMO therapy in patients with severe ARDS. And what they found that in patients with primary ARDS or lung disease, 60-day mortality was not significantly low with ECMO, with a strategy of conventional mechanical ventilation that included ECMO as rescue therapy. So this was actually a negative trial. But I'll just go through a few of the important points as to why it was a negative trial and why individual therapy has to be personalized for each patient group, because there was some outcomes that were actually beneficial. So what we can see here clearly is that, when we look at the Kaplan-Meier curves, there was no significant derivation between ECMO versus control group, and the p-value was 0.07, showing a non-statistically significant outcome. But what's important is that although the primary outcomes, which is mortality and key endpoint treatment failure, was not significantly different, what we can see is that in this particular key secondary endpoint, which is treatment failure at 60 days, we can see that there was a significant difference. But there was no difference in mortality. So in some patients, there was some benefit that was offered using ECMO therapy. Again, when we look at the patients that ECMO was offered to, pneumothorax, what are the complications? We find that the complication rate between the two groups wasn't significantly different. So ECMO didn't, the lack of the efficacy of the ECMO in this particular group of patients was not as a result of the complications that the patients, the complication rate within the patients, but rather as futility of therapy. And for anyone who's looking or is interested in ECMO therapy, this is my last slide. I would strongly suggest that you register your ICU with, with the Extracorporeal Life Support Organization, and they'll give you any form of support that you need in terms of literature, in terms of functional standard operating protocols, and direct support for your patients if you run into problems. Thank you.
Thank you very much, Prof. Kalla, for that stimulating discussion on extracorporeal oxygenation support. Due to the interest of time, of course, feel free to type your questions in the Q&A chat, and I will go ahead and hand it over for introduction of our next speaker. Thank you very much, Prof. Kalla again.
Thank you very much.